Yes, I'd like to welcome you to our webinar pre-conference for the AMSSM Annual Meeting on Top Article Project for 2024. I'm Robert Baker, Committee Chair, Co-Chair with Lee Mancini. Will be presenting tonight, along with our committee members, Jon Stoddard, Jim Dunlap, and Jessalynn Adams. Full disclosure here, and none of us have any financial relationships with any topics or items discussed in the webinar this evening. As far as the agenda, I will give an introduction, an overview of our project that's been going on for the last 5 years. We'll present the honorable mention articles, and committee members, Dr. Jon Stoddard, Dr. Jim Dunlap, and Dr. Jessalynn Adams, as well as Lee Mancini, will present the honorable mention articles. At the end, Lee will finish up with a conclusion and invitation to our session at the national meeting. Tonight, we plan on covering the process and describe the committee approach to determining top articles for the year. We'll examine the honorable mention articles and give you an opportunity to review those along with our committee members and their presentations, including some take-home points for you in your practice of sports medicine. Our subcommittee is comprised here of a number of individuals, all of which contribute significantly by reviewing articles as well as identifying articles. Dr. Mancini has been really handling the lion's share of the committee, and he's the man behind the numbers. And many of the slides I'm going to present this evening were developed by him, so I'll give him due credit. These are our returning members from last year, of which there were 29. We added new members, 22 new members, for a total of 51 members, all listed here. In red, you'll see the new members who joined our group. And those individuals as new members were mentored by individuals that have been involved in the project for some time. This lended us the opportunity to actually review more articles and have the opportunity for more reviewers on each article. And I'll talk about that through the process that we developed this year for our top article committee. Our committee is divided into two subgroups to look at the literature in two different ways. The first group is the core journal group that looks and reviews articles through core journals in sports medicine. And then our second committee group is the keyword or hot topics, topics that are germane or important to sports medicine or have a recent popularity in the field of sports medicine. When we started the project back in 2020, we started with 4 journal articles listed here: the American Journal of Sports Medicine, British Journal of Sports Medicine, Clinical Journal of Sports Medicine, as well as Sports Health. In the following year, we added 14 articles in addition to the central four journals. And those are listed here, looking at a variety of different topics and including other sports medicine and exercise medicine journals. In the following year, we went and expanded to 26 journals as our committee expanded and allowed us more opportunity to review different journals. Committee members on the core journal side were assigned specific journals to review and bring forward any articles that were germane to the topic or unique, judged as good examples of sports medicine articles for the year. The following year, we added Nature and Science, which were subsequently removed. And this year, same 24 journals as last year. These are a list of keywords or hot topics that were reviewed for articles and topics. And you can see most of the important areas of topics are covered regarding sports medicine. We include things that are new and changing as well, including regenerative medicine, orthobiologics, blood flow restrictions, and tendinopathies, as well as transgender and athletes. This year we added 4 more topics with transgender athletes. We added sexual violence, adaptive and para athletes, as well as sleep and consensus and position statements to really cover the gamut of even different types of articles that might be presented that are important to the area of sports medicine. Once articles were identified, these were reviewed by a committee member, actually 6 committee members this year, and on the basis of a standardized score sheet based on these different areas. One was change your practice or practice affirming, and that was the lion's share of 40%. Also evaluated on just the level of evidence and the quality of the study, which was 30% of the final score. And then 10% each was designated as relevant to current issues, breadth of applicability across sports medicine, and relevance to primary care sports medicine. We'll take a look at these specific areas, but this is the composition of that final score, generally out of 100 points, and the weighting of each area from practice changing to level of evidence, relative relevance to current issues, breadth, and relevance to primary care sports medicine. So looking at level of evidence, this accounted for 30%, a score 1 to 10. We looked at the levels of evidence as a basis, but then also included research design as well as presence of bias. So examples, a 10 would be a randomized controlled unbiased research design study, and 1 might be a basic speculation or uncontrolled or animal research. Changing your practice, once again, also rated on a score of 1 to 10. And we asked the committee to review the article and think about if you were a person who did not do this in your practice and you read this article, would you be likely to adopt this practice based on what you read? A yes would be very likely or strongly affirming or definitely will change my practice. And a 1 would be not likely at all or non-affirming, non-change worthy. Relevance to current issues represented another 10%. And topics with media was buzzworthy, current topics. So topics not being talked about fall sort of to the lower end of the scale. Examples here might be, now that we're sort of past COVID, less of an important topic, whereas number 10, the hot topics were transgender athletes, orthobiologics, and some of the newer areas. This represented a subjective component. And then the breadth of applicability to sports medicine. We asked the committee to think of the article in terms of how it applies to everyone who practices sports medicine, or how it applies to all of sports medicine patients. If it's very widely applicable, it would get a 10. Low or narrow applicability would be 1. Examples here, an article on a professional baseball player, maybe with UCL injury, to a specific population in Japan versus an article that might cover all of concussions. Articles on bone health, for example, of folks that may be over 60 compared to people under 20. And then finally, articles on professional female soccer players, including all ACL tears versus an article that's limited to female, or includes all or just female soccer players with ACL tears. And then finally, relevance to primary care sports medicine. on how the article applies to those who practice sports medicine and orthopedic sports medicine. Not to rate this on your own personal practice, but consider the whole of sports medicine. So if it's very relevant, gets a 10, not very relevant would be a 1. And the article on a new type of ORF or hardware tibial fractures may be out of the realm of what you might consider important to sports medicine, where an article on a new ACL graft outcomes for ACL tears might be more germane. Even more germane might be exercise on mental health, which lies in the area of primary care and sports medicine. And this also represents a subjective component to the rating system as well, as compared to the level of evidence. So looking at our adaptation and changes over the year, we added 4 new keywords to our hot topic, as I discussed previously. And we went from 35 to 52 members. So the new members, as I talked about, were paired up with members who had been on the committee previously to help mentor and guide, direct, and reviews, and those were reviewed individually. So on to some of the numbers and search results of articles identified. Looking from 20 to 23, here are the numbers in our first year. Core articles numbered 43. Keyword articles were 28 for a total of 71. And you can see in the following year, in 2021, we jumped to 142. And then in 22, we jumped to 375. In 2023, we had 281. And you can see which came from the core subcommittee versus the keyword subcommittee. This year's results and review of the literature identified core journal articles of 307, keyword or hot topic articles numbered in 174 for a total of 481 articles. With 6 reviewers, that came out to 2,886 individual reviews. And that was just our initial review. So here you see the comparison. We jumped from 71 5 years ago to all the way up to 481 this year. 307 of those were identified in core journals, and another 174 were identified as keywords. So rating of articles for this year, to give you an idea of the numbers, and once again, I thank Lee for putting together all of these statistical numbers. But first article score was the 82 out of 100. This was a bit higher than 2023, but in line with that. You can see that it was 79.65 in 2023. Our last or lowest article this year was 32. And in 2023, 29. Here's where the quartiles fell out in comparison to 2023. You can see they're fairly close from the first, second, third, and even down to the fourth quartile. The average was 59, similar to what we saw in 2023. And then the standard deviation was a little bit more fine-tuned this year compared to previous, but still in the same neighborhood with 8.27 compared to 9.36. Once the articles were identified, we took the top articles. The committee met and decided which was the cutoff for re-reviewing articles. We wanted to re-review the top articles and get a number of folks to get their opinions on the different articles. So regarding re-reviews over the last couple of years, in 2020, we had 14 articles that we reviewed, and that was the top 20%. In 2021, there were 35 articles that were reviewed a second time, and that represented the top 25%. In 2022, we went with the top 10%, and that represented 39 articles that were given a second look. We met as a committee, discussed guidelines and cutoffs and what was reasonable to review based on committee members. And the top 10%, as was seen previously, out of the 481 articles were reviewed for a total of 48 articles that were reviewed a second time. The second time we actually had 8 reviewers, and that represented 14 total reviews. Number of re-reviews was 8, increased from 6 in 2023. 14 different members in the end were able to read, review, and rate these articles to get a more fine look at the articles and discernment. So here's this year's cutoff for second looks. 2024, we had 307 core articles, as I mentioned before. 174 were keywords for a total of 48. 481, excuse me, and then the top 10% of that 48 articles were reviewed a second time. Here's final article cutoffs, which the committee met final time, looked at the articles and determined a cutoff both for the top articles and then to include other articles that maybe were reviewed a second time as sentinel articles, but didn't quite make the cut. We evaluated those articles and out of those chose honorable mentions as we're going to present tonight out of our 2024 data. You can see from previous years in 2020, we started out with no honorable mentions. In 2021, we included the category of honorable mention, of which we had 5, and subsequently 5 and then 6. So out of our final list of top 48 articles, we rank the top 10 articles that will be presented at the conference. We also, as a committee, chose 8 honorable mentions out of the 48 articles, and those will be presented tonight by our committee members. So once again, you can see the comparison 2024 from previous years. Top articles, once again, we kept with the number of 10. That was a natural cutoff, and then included 8 articles that we felt, the committee felt were important articles to be included. I'll take this opportunity to invite you to our session of top 10 articles at our annual meeting. It's going to be session 16. It will be the last on Sunday, April 27th from 9:45 a.m. to 11:15. We'll have committee members presenting those articles from 10 down to 1 with comments from a panel of experts on the CRN and including top articles and CRN highlights. That's an overview of the process and update on changes that we made to the protocol this year. And at this point, I will hand it over to Jonathan, who will present the first 2 honorable mention articles.
All right, thank you, Dr. Baker. Jon Stoddard coming to you from Fort Cavazos, Texas. So as I am active duty military, just one additional quick disclosure before I begin. The views expressed here are my own and do not necessarily reflect the official policy or position of the United States Army, the Department of Defense, or the U.S. government. So with that, we will get into our first honorable mention article. So this article is entitled the 2024 HRS Expert Consensus Statement on Arrhythmias in Athletes, Evaluation, Treatment, and Return to Play. This article was published in October of 2024 in Heart Rhythm, with the lead author being Dr. Rachel Lambert, who comes to us out of Yale University, with a cohort of several authors from all across the country, and additionally including a couple of international authors as well. So the primary aim of this article was to guide electrophysiologists, sports cardiologists, and associated healthcare team members in the diagnosis, treatment, and management of arrhythmic conditions in the athlete, with the goal of facilitating return to sport and avoiding the harm that is caused by restrictions. Their additional goal was to provide evidence-based recommendations impacting all areas in the care of athletes with arrhythmic conditions. So to give you all a scope of the overall breadth of this article, so the full manuscript is 102 pages in length, and there's a reference list of 733 citations. The article is broken down into 11 sections with 2 additional appendices. So all that to say that the authorship team really put in the work on this one. So here's a condensed version of the table of contents to orient you to what is contained within this manuscript. So it covers topics including sudden cardiac death, commotio cordis, symptoms of arrhythmias, ventricular arrhythmias, inherited arrhythmias and cardiomyopathies, AFib, WPW, bradycardia with pacemakers, and then some recommendations for further research, and then additional information in some appendices as mentioned previously. So please don't attempt to read this chart, but I just wanted to share with you how they went about rating their recommendations throughout this article. So they use the ACC-AHA recommendation system. So in the left-hand column, you will see the class or strength of recommendation and an example of how those recommendations are graded there in the blue and, in the green and yellow. And on the right-hand side of the screen, in the shades of blue, is an example of how they rate the level or quality of evidence throughout each section within the article. So here's an example of one of the charts that provides the recommendations. So I pulled this snippet of a chart from the section on sudden cardiac arrest and implantable defibrillators. So again, in the far left column, you'll see the class of recommendation ratings in the yellow and green. In that middle column in the shades of blue, you see the level of evidence ratings. And then, of course, in the far right column, you have the actual recommendations themselves in the free text. So there's a table with this presentation in each of the sections. So very useful, very easy to read and review the evidence ratings there. So really the bottom line with this article is it is an excellent reference article to aid in medical decision-making for athletes with arrhythmias that is guided for you by consensus opinion, level of evidence, and class of recommendation ratings, and it does focus on a multidisciplinary team. As much as I would love to summarize the entire article for you, unfortunately, that is just outside the scope of our presentation. But definitely highly encourage you to download this article, save it, and keep it as a reference for when you have some of those more challenging cardiac patients. All right, so moving on to our next article. So our next article is entitled Exercise Interventions and Intelligence in Children and Adolescents, a Meta-Analysis. So this article was published in Pediatrics in December of 2024 with the lead article of Dr. Morales and colleagues here, and this authorship group comes to us from Spain. So the primary aim of this article was to determine the effect of exercise interventions on intelligence measures in children and adolescents. So for their study design, they created a meta-analysis in which they ultimately selected 14 randomized controlled trials. These RCTs compared an exercise intervention group with a control group. The median exercise intervention duration was 12 weeks across the studies. And within these 14 studies that yielded the group of 3,202 total participants, and their ages ranged from 5 to 14 years. The primary analysis that they looked at were intelligence measures, which we'll dive into more detail in the subsequent slides. And some of their secondary analysis included looking at moderating effects of the patient's baseline IQ, their age, and then the duration of the exercise intervention. So looking at their results, they first looked at general intelligence measures, and the measures that they used are listed at the bottom of this slide. So when they looked at this, they noted that exercise significantly improved general intelligence compared to the control groups with a standardized mean difference of 0.54, which yielded a 95% confidence interval of 0.11 to 0.97, and that had a p-value of 0.01. When they broke it down further into looking specifically at IQ score, which is a measure of intelligence that those of us here in the United States will be the most familiar with, they noted a mean difference of an increase of 4.0 points for the exercise group compared to the control group. This had a confidence interval of 1.4 to 6.6 with a p-value of 0.003. And then when they controlled for low versus normal baseline IQ, the patient age, as well as the duration of the intervention, these results held. Breaking it down further into some subcategories of analysis that they did. So they also looked at fluid intelligence. So what is fluid intelligence? Fluid intelligence is the ability to think abstractly, solve novel problems, and reason flexibly, independent of prior knowledge or experience. So when they looked at this, they additionally noted that exercise significantly improved measures of fluid intelligence compared to control groups, although it was of a lesser degree compared to the general intelligence measurements with a standard deviation of 0.2, confidence interval of 0.06 to 0.34, p-value of 0.006. They additionally looked to analyze crystallized intelligence. So what is crystallized intelligence? This is the knowledge and skills acquired through experience, education, encompassing facts, information, and expertise. Unfortunately, they were not able to meta-analyze this subgroup as they did not have enough data. So effectively, the study was not adequately powered to look at crystallized intelligence. Some limitations of this study. So there were two areas of heterogeneity that provided some limitations. So the first being the characteristics of the exercise interventions. There's a large amount of heterogeneity in exercise type, intensity, duration, and frequency. So the authors were unable to comment on which form would be optimal. And then additionally, there was some heterogeneity within the population studied, particularly referencing the participants' medical history. And then, of course, as mentioned, they were unable to analyze the crystallized intelligence. So the bottom line for this article is that the findings suggest that exercise interventions are associated with improvements in general and fluid intelligence in children and adolescents. And the authors recommend further study to evaluate optimal exercise intervention characteristics for improving intelligence measures in youth. Thank you for your time, and with that, I will turn it over to Dr. Jim Dunlap to present our next two articles.
Thank you, Jonathan. From a snowy Maine evening, I'd like to present early surgery versus exercise therapy and patient education for traumatic and non-traumatic meniscal tears in young adults, an exploratory analysis from the DREAM trial in the Journal of Orthopedic Sports and Physical Therapy from May of 2024 by Kama Damstead and others. So this was a randomized controls trial on exercise versus arthroscopic meniscal surgery for young adults ages 18 to 40 with MRI verified meniscal tears. 121 patients were randomized to either surgery or 12 weeks of 2 60 to 90 minute sessions per week of supervised exercise therapy. They were further stratified into non-traumatic or traumatic meniscal tear groups. They used the COOS-4 and Western Ontario Meniscal Evaluation Tool to collect patient-recorded outcomes at baseline, 3, 6, and 12 months. They also used additional statistics in the larger parent study back in 2017 by Scow and others. The meaningful clinical difference for WOMAT was defined as 15.5 points and 10 points for the COOS. However, as an exploratory analysis, this study was not powered to detect those differences, but rather was looking at the differences between the surgery and exercise groups. They performed a protocol analysis that excluded subjects that crossed over or failed to complete greater than 17 exercise sessions. They performed a sensitivity analysis that evaluated the robustness of the model by excluding patients with semi-traumatic injuries, for example, kneeling, sliding, twisting. When you look at the overall allocation, they were equally allocated. When you look below, you can see in the surgical group that 8 did not receive surgery, 8 in the exercise group crossed over in the traumatic group, and another 8 in the non-traumatic group crossed over to surgery, and then another 15 failed to complete the exercise sessions. So overall, 39 ended up not being included in the per protocol analysis, but were included in the main analysis. As you look at the baseline characteristics, it's important to recognize that early does not mean early surgery, rather early in the study. When you look at duration of symptoms, you see that it ranges from 0 to greater than 24 months. And then as you look closer, you can see that the study was also not powered sufficiently enough to evaluate the duration of symptoms, the type of repair, patient age, and anatomic tear pattern. Results. In the main analysis for traumatic tears, there was improvement in each of the groups with both the KOOS-4 and the WOMAT total scores, 18.8 versus 16.0 and 26.3 versus 18.8. As you look at the non-traumatic tears, the same findings, 20.6 in the surgery group versus 17.3 in the exercise group, and similarly 14.4 versus 18.9 in the exercise group. When you actually control for the center, age, and sex, the difference is actually negligible between the surgical and exercise group. They also performed a main analysis and a sensitivity analysis for the KOOS-4 scores, and you can see that the improvement levels off at about 6 months. But as you get to the end, there is no statistically significant difference between the surgical group for atraumatic and traumatic meniscal tear groups. All groups improved. So conclusions and take-home message. Early meniscal surgery was not shown to be superior to supervised exercise therapy. Both groups improved over 12 months. However, on 2 of the WOMAT scales for traumatic tears and the KOOS sports and recreational subscales for non-traumatic tears, surgery trended towards having a meaningful difference that should be explored in a larger study. And now if we did shared decision-making, one can recommend exercise therapy as being a non-inferior approach to meniscal tear surgery, with an admonition from the authors of the sample size limitations. Moving on to our next study, does headgear prevent sports-related concussion? A systematic review and meta-analysis of randomized controlled trials, including 6,311 players and 173,383 exposure hours in sports health in May, June of 2024 by Al-Attar et al. The study design, excuse me, is a systematic review of randomized controlled trials published between 1985 and 2023. They looked at 366 records through the usual databases. Ultimately, they ended up with 3 randomized controlled trials, including the analysis, 2 from Australia, 1 from the US, all youth players aged 13 to 20. The inclusion criteria are listed as you see: randomized controlled trials without consideration for age, gender, or playing level. Exclusion criteria that cut out 3 randomized controlled trials included non-RCTs, failure to record player exposure hours, use of different kinds of protective gear like face shields or mouth guards, and failure to report sports-related concussion rates. The incident rate was defined as the number of concussions divided by hours of exposure times 100. The relative risk was defined as incident rate in the concussion headgear group versus the non-headgear wearing controls. The risk of bias was defined through the Pedro relative risk of bias scale. It's a 10-item scale. 2 of the studies scored 8 out of 10, 1 scored 6 out of 10, all falling into the good category. Results. This is a table showing the sports-related concussion rates per 1,000 hours of exposure in the experimental and control groups of included studies. So 3 studies, including 6,311 patients with 286 concussions. You can see as you look at the risk ratio that it includes 1, meaning that there is no statistically significant difference among or between the groups. Furthermore, they performed a forest plot showing no significant difference between headgear and no headgear groups. And this again is a risk ratio that includes 1, suggesting that there is no statistical difference. However, because only the McGuine study included female subjects, which included 108 concussions, I actually went back to look at that article. It was broken down into 43 sports-related concussions, or 4.2%, in the headgear wearing group versus 6.5%, n equals 65 in the non-headgear group. The p-value was 0.154, or no significant difference. The conclusions: in rugby and youth soccer players, the use of headgear does not appear to reduce the risk of sports-related concussion. The data for female soccer players is less robust and merits further study. Thank you, and I will now turn it over to Jessalynn Adams.
Hi, everyone. This is Jessalynn Adams joining you from Alexandria, Virginia. And my 2 articles will start with the article by Biesecker et al. This is an article that comes out of UNC Chapel Hill and the University of Kentucky, looking at depression, anxiety, and stress among female student athletes. So this article was a systematic review and meta-analysis. They screened over 2,000 articles, and there were 2 reviewers. They looked at 5 online databases and ultimately included 52 studies, and 13 of which were used for the meta-analysis. I won't have you read the whole flow chart here, but this is their process for selecting and excluding articles. The primary search terms were female athletes, DSM-5 diagnosis of anxiety or depression, stress, participation at a United States NCAA institution, and mean age greater than 18. They excluded any studies that were case studies, case reports, secondary analysis, or other diagnoses or studies that were not in English. The majority of these studies focused on Division I athletes with ages between 18 and 27. Ultimately, 18 studies on depression and 18 studies on depression and anxiety, and 4 that also included stress. So they used multiple validated measures of depression and anxiety, specifically the ones that you see here. Essentially, this study highlights the growth in the research on female athlete well-being and mental health in the last decade in particular, but especially since 1973 when Title IX was enacted. And they found that there's a higher prevalence in reporting of depression, anxiety, and stress among female student athletes. And these are likely from multiple factors, including COVID-19, lack of social support, sleep, and then injury as well as concussion. So the take-home points: if female student athletes have higher rates of depression, anxiety, and distress, and this highlights multiple areas for possible interventions in the future, including addressing an at-risk population, encouraging good sleep hygiene, and offering additional support, as well as prioritizing wellness strategies. The second article that we included was looking at interventions to prevent falls in older adults. This came out of JAMA by Gargis and Blake et al., and was also a systematic review and meta-analysis. So they looked at nearly 5,000 studies and included randomized control trials from 2016 to 2023. There were also 2 reviewers in this study, and they found 83 fair to good randomized control trials. They included randomized control trials of community dwelling 65 and older adults, with primary or secondary aim being prevention of falls. So this is how they selected those citations. It's quite a lot of citations to parse through. They did exclude studies that did not have a control group or that looked at 2 or more interventions. So they really wanted to look at exercise in particular as the primary intervention for fall prevention. They also excluded any studies that primarily focused on specific populations, such as those with moderate to severe dementia, those that were not in the community dwelling environments, or that looked at assistive technology, nutrition, other types of interventions. So ultimately, these were the 83 trials that they looked at, and then they also included 30 trials for their second clinical question. So question 1 was looking at, do these interventions prevent falls in the community dwelling population? And then also, is there any harm of these interventions? Their main outcomes were looking at falls, injurious falls, multiple falls, and falls that resulted in fracture. They did not consistently report any harms for any intervention. So the largest body of their literature looked at these multifactorial and exercise interventions, both of which were found to decrease the risk of falls in average to high risk older community dwelling individuals. They did not find that these seemed to impact the number of falls or morbidity associated with them. So main take-home points are that falls are a leading cause of injury in the 65 and older population. And this was an update from the US Preventative Services Task Force review from 2018. Essentially, it included 3 new multifactorial trials as well as 19 exercise trials, and reaffirms that both of these interventions reduce the risk of falls in older adults. Thank you, and I will turn it over to Lee Mancini for the remaining 2 honorable mention articles.
Thank you so much, Dr. Adam. And again, I'm coming to you from Worcester, Massachusetts. I'm Dr. Lee Mancini, the Chief of the Division of Sports and Exercise Medicine at the UMass Medical Center and the Director of the Sports and Exercise Medicine Fellowship as well. And my first honorable mention article is The Effects of Acute Sleep Deprivation on Sporting Performance in Athletes, a comprehensive systematic review and meta-analysis from Nature and Science of Sleep. And this was a study that was published and run by research from the People's Republic of China by Dr. Gong. So this was a systematic review and meta-analysis. It asked 3 main questions. Does sleep deprivation negatively affect athlete sports performance, and to what extent? 2, what specific negative effects does acute sleep deprivation have on athlete sports performance, and are there variations in these effects? And 3, how does sports performance differ in the morning and afternoon following acute sleep deprivation? And this is the key. This study really looked at acute sleep deprivation, not chronic. So again, in culling through the database and the research, the PRIMSA guidelines were used. Of note within their exclusion criteria, so this was a study that was done in the People's Republic of China. It excluded non-English and non-Chinese articles. So they included English and Chinese articles. They excluded abstracts, dissertations, conference papers. They excluded all methods of sleep deprivation that was non-acute, meaning any sleep deprivation that lasted more than 1 week, and in any case where the data both before and after the sleep deprivation was incomplete. And here you can see that, again, the PRIMSA flow chart. And to summarize, they used 27 eligible studies from what they started out with. In those 27 studies, 25 of them included only males, and 2 studies included both males and females. When you looked at the total subjects, there were only 9 females that were looked at and 360 males. The age range was 15 to 33. And then when they were looking at effect size, they used tiny as less than 0.2 for the standard mean difference, up to large of greater than 0.8 for the standard mean difference. They looked at a variety of different sports that were mentioned in those 27 articles, but 8 of those 27 studies did not actually specify the sports. You can see here basketball, football, a lot of martial arts, weightlifting, sprinting, cycling, tennis, and triathlon. The other things they looked at within those 27 studies were all the different performance indicators, and there were 75 different performance indicators from areas of explosive power, like a counter movement jump, to speed, to high intensity interval exercise, such as the yo-yo test or repeated sprint ability tests, aerobic endurance, skill control, such as, a serve in tennis, shooting, juggling, and so forth. So these were all some of the highlights of the different markers of performance indicators. When they looked at the type of acute sleep deprivation, they broke it into 3 categories. SD was over the entire night. So someone was up all night and they didn't get any sleep. PSDB was partial sleep deprivation, but in the beginning, meaning that these were studies where people delayed going to sleep. So instead of going to bed at, let's say, 9 o'clock or 10 o'clock at night, they stayed up much later. And then PSDE was partial sleep deprivation at the end. So this is where athletes in these studies got up early in the morning. So E means at the end of the night and B is at the beginning. And when we looked at all the different studies and looked at the different categories for exercise, whether it was power, speed, endurance, or skill, what you found was that when it was the end of the night, so getting an athlete up earlier, that had a greater effect, more significant effect on reductions in explosive power, in speed, and high intensity intermittent exercise. And if you look here on the boxes in red, this showed that when it was at the beginning of the night, as people pushed their bedtime later, and that was when the deprivation occurred, that caused a greater delay or a greater worsening or drop in performance of aerobic endurance and skill control. So the take-home points for this honorable mention article by Gong was that acute sleep deprivation significantly impairs overall sports performance. I think that's something that everyone's aware of, but there's actually an adverse effect hierarchy where higher intensity intermittent exercise is most impacted by sleep deprivation, then skill control, then speed, aerobic endurance, and explosive power. And that was looking at the effect size. And that skill control is impacted after an acute sleep deprivation, both in the morning, performing in the morning or in the afternoon, whereas overall sports performance, explosive power, and speed tend to show a greater drop-off in the afternoon, whereas aerobic endurance tends to show a greater drop-off in the morning. And this can be used, this meta-analysis and systematic review can be used to look at optimizing athletes in different sports training schedules. Does an athlete train in the morning or later in the day based on their sleep deprivation, but also for travel, for team sports or for individuals, where it may be better to travel the night before than to get up early and travel the same day. So those are the take-home points on this article. The last honorable mention article for our group to present out of the 8 is the 2023 IOC consensus statement on REDS, relative energy deficiency in sport, by Dr. Mountjoy and an outstanding team of experts. REDS was first introduced in the 2014 IOC paper in British Journal of Sports Medicine with an update in 2018. The 3 goals of this consensus statement that was published was to summarize the recent scientific advances in the field of REDS, 2, to introduce a novel REDS physiological model template and the validated REDS CATS 2 system, which is a new clinical assessment tool, but it's the version 2, and to provide practical REDS-related clinical and methodologic research guidelines to promote athlete health and well-being, along with safe optimization of sports performance. To summarize, there were 5 real parts the way this consensus statement was broken down to. 1, what is REDS? 2, looking at the methodology and the consensus results. 3, the key scientific advances that have occurred in the years since the last REDS consensus statement, clinical applications, and research guidelines. When they looked at how to rate consensus for some of these expert agreements, they used the RAND UCLA appropriateness method. They used expert agreement with a Delphi method of 3 levels. Agreement or full agreement was greater than 80% agreeing on a vote-in statement without any author disagreeing. Agreement with minority disagreement was greater than 80% of the experts agreeing, but with 1 or more authors disagreeing. And then disagreement was less than 80% of authors agreeing. And when you can look here, out of the initial 135 statements, there was full agreement in 76. And by the end, out of the total of 144 statements, there was 117 with full agreement and only 27 with minority disagreement. And none with disagreement where it was less than 80%. A couple of key things I wanted to highlight on this article was this concept with low energy availability of adaptable LEA versus problematic LEA. Adaptable LEA is something where you start off with benign effects of low energy availability, and it's monitored and it's mindful, where people are trying to change body composition, but it's short term and there's minimal or no impact on long-term health, well-being, or performance. And then again, problematic LEA is what can lead to or is a huge indicator or issue with REDS, and that's greater or potentially persistent disruption of body systems with a maladaptive response. So I think that was one really interesting take-home point for this article, is the concept of adaptable LEA versus problematic. They did publish an updated definition of REDS that I wanted to make sure everyone got a chance to look at here. I'm not going to read the whole piece. And then they presented the REDS physiologic model, where step one, with each body system, they ID'd a range of specific health and performance impairments from low energy availability exposure. Then step two is focusing on an athlete's LEA exposure and why it may create a higher risk for that athlete, both in duration, magnitude, or the cause or origin. And then to look at, for an individual athlete, moderating factors for that individual that might either protect them against problematic LEA or lead them to be more at risk or exacerbate into problematic LEA. This was the REDS conceptual health model. It has 14 different components of areas in this wheel on a spoke, and you can see how LEA, specifically problematic LEA, affects all of these areas. And then there was another spoke and wheel model that looked at the performance conceptual model in these 8 different components in terms of athlete performance and how low energy availability affects that. With the clinical assessment tool, there were some changes. The more recent one, the CAT2, expanded from the 3-color model that came out in 2015 to 4 colors. So now there's green, yellow, orange, and red, all basically modeling different risk categorizations and severity of REDS. It's a more concrete scientific framework with a scoring system, and it looks at sort of primary and secondary indicators. And again, one thing to make sure we know is that there's no singular validated diagnosis method for REDS, because it's a syndrome that has a complex mosaic of signs and symptoms. And again, with this new version, it's that 3-step process in looking at implementation of that screening system and questionnaires. Then we implement the IOC REDS CAT2 severity risk assessment, and then that leads to an expert physician diagnosis. And this is really that color system. You can see green on the left with a very low severity risk, going then to yellow, and red, and orange, and then red, which has that higher severity risk. So 6 key take-home points from this article. Excellent consensus statement update was: 1, the additive impact of low carbohydrate availability with LEA in the development of REDS. 2, that there's an overlap between REDS and overtraining syndrome symptomatology, and it's important to understand which one you're truly dealing with. The 3rd take-home point was the time course of biomarker responses to problematic LEA in the development of REDS. 4 was an improved understanding of mental health associations of REDS. And then 5 was advances in understanding how REDS involves with male athletes. And 6 was advances in knowledge pertaining to REDS in para-athletes. So that sort of summarizes the key take-home points from this honorable mention article from Mountjoy. So in summary, I wanted to thank Dr. Jon Stoddard, Dr. Dunlap, Dr. Jessalynn Adam, and Dr. Bob Baker for his introduction. These are our 8 honorable mention articles that we've just reviewed. And then last, I want to thank the AMSSM Education Committee, the AMSSM Fellowship Committee. We are an official subcommittee under the Education Committee. Dr. Bob Baker and I are the co-chairs. This has been the 8 honorable mention articles and our methodology for choosing the articles for 2024. But please, again, we hope everyone tunes in to watch on Sunday, April 27th, starting at 9:45 a.m. to 11:15 a.m. in Kansas City. It's the last session of the conference. It's practical application from the cutting edge of research. It's the top articles of 2024. You get to hear us count down on those top 10 articles, as well as the CRN highlights. Also, we're always looking for more members. We were able to have an amazing group of 51 members this year who really did a ton of work going through, again, close to 500 articles. And we would love to have more members join and help us out. And so if you want to get involved, please email me at either one of these 2 email addresses, because we'll be starting in May on the top articles of 2025. So again, thank you very much. And thank you everyone for tuning in to listening to this webinar.